I'm Dr. Bryan Keropian, and I'm new to the ASBA, about 8 months. Got my Diplomate. I love it in here. I love the camaraderie of that group, and I really think we have some great stuff going in here. I'm a longtime member of the American Academy of Craniofacial Pain, and there's a whole slew of fellas in here that are from there. Larry Tilley, I see Elliot Alver, Steve Wilkes, Richard Klein, and Romrell. I don't see him here, but anyway, we've got a lot of them. So these are all guys that are going to be able to help you with TMJ. I have a brand new paradigm for treating sleep apnea. Some of you may like it. Some of you may think I'm coming from Mars. But it's new, and one of the things I really appreciated about with the American Academy of Craniofacial Pain, we were open for all ideas. We wanted everyone to present their idea free from real negativity and nasty remarks. And if you're not happy with what I have to say, I understand that. Be courteous, tell me what you don't like, and we'll discuss it. So anyway, and some of you may absolutely love it. I apologize for not having a tie. I can't believe I forgot my tie. Here I am, professional, up here from California. You think I'm a California hippie here, except I don't have my Jesus sandals on. And I'm ready to go. All right, I've got 2 offices, one over in Beverly Hills and one in Encino. That's where Michael Jackson was. And you can see where I went to school. And right down here, this football picture here, that's who Las Vegas has as the odds-on favorite to win the Heisman. Sam Darnold, their quarterback. And we're real excited. Okay, I was asked by Dave Gergen, now in Hickey, to give a lecture on the new paradigm of TMJ treatment I had presented to them. And the basis for this new paradigm for TMJ is based on a new paradigm treating OSA. A portion of this lecture will be to provide you the new paradigm of OSA that applies to TMJ. So I'm going to start out with that, and you're going to be saying, well, how come he's not talking TMJ yet? Okay, what are the 4 most dangerous diseases on earth? And we can have all kinds of ideas, and there certainly are. But these are my opinions of what they are. 1, hypoxia, a state in which the oxygen supply is insufficient to the body. 2, hypoxemia, refers specifically to low oxygen levels in the body. And when you deal with the insurance companies and you use hypoxemia with them, they almost fold their tent. They do not like hypoxemia and are scared of it. And you will get better treatment plan acceptance from the insurance companies if you look for the mean O2 being low. And the 3rd one is acidosis. It refers to the body being too acidic, and it occurs with hypoxemia. Now, do we see this? This is what we're treating. This is it. OSA is about hypoxemia, hypoxia, and acidosis. Okay, with OSA, the O2 supply to the lungs is more minimal. The ratio of oxygen to CO2 in the lungs is reduced. Okay, well, that makes sense. The CO2 is acidic, and the lungs become acidic because there's a higher ratio of acidity in there. This is known as respiratory acidosis. Now, if this acidic gas in the lungs gets expelled, the body becomes acidic. That's one of the contributors to the body becoming acidic, and it's referred to as metabolic acidosis. Acidosis is dynamite, is not good. All right, this you know. We got the Somnomed and the TAP, and there's a whole slew of them. And this is what you treat with. Here's the new kid on the block. This is mine. the full breast solution with and without O2 tubes. Well, what do we got up here? Right up here. We've got a bruxism appliance with a transpalatal bar, and we've got wires coming out, flexible wires. It's crow's-out wire. It's strong as hell, because the labs were very worried about this break-in. Of course they are. We use real strong wire, and we've got a little plate of plastic. Now we can bend these wires back, make this wider, and we make the tail longer. And we can bend it down. Well, why do we bend it down? To open the airway, push the tongue out of the way. And at 2 in the morning, when we get, with these airway metrics, we get these big readings in the office, ours is going to hold because we've got the tail stopping, inhibiting the tongue. And here, we've added oxygen tubes. And we're going to talk about why the heck would I add oxygen tubes? Well, we know they're CPAP intolerant. Nice that we can get oxygen, but we're going to talk about the real role of oxygen and what the destruction of the oxygen and the acidosis is to the body, and what we as dentists can control this. And here we are, just showing you, we've got 3-prong pliers here, and I'm pulling this away from the transpalatal bar, and I can move it over here, move it out wider, and we've made the tail longer. I can adjust this mouthpiece in literally 2 or 3 minutes. Pliers, take it longer, bend it down. I use the pharyngometer on every one of these patients, and boy, can we see the difference in the airway. Big time. And the patients can see the difference, and they love it. All right, here's the market size of those that snore and have OSA. Now, you may have some different figures. These are the figures I got. The National Sleep Foundation reports that 56% of American adults snore 3 times a week. 88 million. It's our market. 27% of all American couples sleep in separate bedrooms due to snoring. This was in the Wall Street Journal. Are you kidding me? 1/4 of all couples sleep in different bedrooms? Holy smokes. Okay, now we've got the full breast solution. We start with the master, Otto Warburg. All right, I'm kind of curious. How many have, besides those who have taken my courses, how many have heard of Otto Warburg? Raise your hand if you've heard of Otto Warburg. Take a look. There may be 5 or 6 people. You know what? An absolute crime. It really is. And when I first stumbled on Otto Warburg, and I've been studying, I've taken courses all over the country. Larry's taken courses, Elliot's taken courses, Klein's taken courses. How could we not hear about Otto Warburg? Well, here's who he is. Read this. Jewish physician in Hitler's Germany. 1931, he won the Nobel Prize. And it was for this. Discovered that hypoxemia, low oxygen, resulted in increased cancer, infection, virus, and produced acidity. I mean, this was shocking to me when I stumbled onto this. And that disease, look at the bottom one, disease cannot live in an alkaline body. All right, read this. I want you all to read this. Okay, armed with this knowledge, that this is one of the reasons I wanted to change the paradigm of what we're doing. All right, we used to make the full breath plastic tail, and we would make it longer. Problem was, it would take 30 minutes to 45 minutes to do it, and as such, this never really caught on. As soon as I went to a metal tail that could be flexed in the last 6 months, the interest has zoomed, gone up, because it's easy. Patients in there and out in 5 minutes after you've seated the appliance. If oxygen is the key to the limiting or eradication of disease, then dentistry with its oral appliances is the key to aiding mankind in this endeavor. Boy, that's a real mouthful. That's saying that we're going to be able to really move up the line in the way of health maintenance and longevity. And I absolutely believe that we can, especially with what we've got here. And I want to show you the data behind why I'm sitting up here and giving you my opinion. According to the National Sleep Foundation, we already talked about this, 56% of the adult population snores. It's 313 million in this country, 88 million snore. All right, what percentage of these 8 million snorers suffer with OSA? Well, we got all kinds of guesses. 20%, 40%, 50, 60%. I decided to undertake my own study. I had a great database in my office. I took patients who came in from 06 to 09 without a PSG and were snoring. Run the PSG and let's see what the spread was of apnea. Here we are. 404 normal. 12 patients out of 273. 4% were normal. Mild, 57, 21%. Moderate, 79, 29%. Severe, 44%. I don't know why we fell out of here. And then we had 2% over 100. What's the significance of this? Well, first of all, 4% were normal? You mean to tell me 96% of the patients in this study, with no sleep studies before, had sleep apnea? Now, does that hold true in every practice? I can't answer that. Could this be flawed? Well, let me tell you where I think the flaw could be. These people came in with a problem. So could I be off? Absolutely. Could I be off 50%? I don't believe that. Could I be off 20%? Maybe. But I think the fact that apnea is a lot higher than we think it is. Now, based on this, 25% are less than 15. Now, why is 15 significant? That's where the insurance and Medicare starts to pay. So 75% fall in the category of they're going to pay. And what really amazes me is we've got 46% are severe. Well, geez Louise, that's almost half. Now, does this hold true in every practice? We don't know. Well, I'm hoping to bring this to the ASBA, and we're going to get some more data and have some of you guys present some more data, and for us to get this a lot stronger to the whole country. Are you ready to redefine the parameters of success? Yeah, let's get rolling. 3 years ago, I stumbled onto Warburg and his research. I realized we needed a big change if we wanted dentistry to help our patients, our communities, and to achieve a new level of success. Okay, as dentists, we treat OSA to get the patients more O2. We use AHI and mean O2 to change our success. However, I sat in 3 lectures. Everybody talked about AHI, AHI, AHI. Nobody talked O2, mean O2. What are we trying to do? Why do we want a low AHI? So we can get more oxygen. AHI and mean O2, which is the more important stat? How many feel AHI is the most important stat we get? How many feel the mean O2 is the most important stat? Raise your hand. Let me see. Come on. Okay. Well, about half of you raised it for the mean O2. I believe mean O2. I mean, AHI tells us we should be getting more O2. However, with the full breath, we're getting some contrast to that, and we're now opening up the argument of which is more important. Our goal is to get the patient more O2, and concurrently our OSA treatment can reduce hypoxemia and acidosis. Well, of course it can. We bring the oxygen in, we're not going to be hypoxic. No acidosis. Okay, of the MDs I pulled, non-scientifically, in other words, talking to them, meet them in a meeting, the MDs believe the AHI is more important. The dental community, and I hang around mostly guys that are at full breath, they believe it's the O2. And as from what we got here, 50% raised their hand here. Now here's something we really don't look at. But as I ran into all this, I had one particular case where the guy had a very high post-treatment, 35 was his AHI with oxygen. Oh, that's a disaster. But his oxygen was 96.7. Is that a winner? I sure think it is. So I talked with a guy named Ron Schmuziak. He's a researcher at UCLA Sleep Center. He also was the editor of the journal Sleep for the AASM. He told me if you have high O2 and you've got low arousals, you're getting good oxygen, good sleep, game over. Don't worry about the AHI. So I've been living with that. Now whether that's scientifically correct with all of them, and I tell you, I got some MDs that argue violently that that ain't right. Arousals of less than 20 are normal. The lower number, the better the quality of sleep. The higher number over 20, the poorer the quality of sleep. And I mean, I see stuff when I really start looking at this now, and I check it on every case now. I mean, I see 50, 60, 70. Not good, not good. All right, here's what I want you to see. This is a 40-patient clinical study with the full breath solution. We took pre-treatment PSGs at labs throughout Southern California, and we took post-treatment PSGs with the full breath, with the oxygen, connected to a concentrator. And they were getting 92% oxygen. That's what the concentrators from Respironics deliver. And we were giving it 1.5 liters per minute. Okay. Well, unfortunately, as we've changed from one slide group to another, we got, which shows here, 38, I can't see the bottom of all these numbers. That's what I'm not happy about. 38 of the 40 patients had final mean oxygen saturations from 90, above 95. We also had, their beginning AHIs were about 38, and the final AHIs were 13. And we had the mean O2s about 96.8, and the arousals for this group were 16, less than 20. 20 of the 40 patients had post-treatment AHIs below 5. Well, geez Louise, that's damn good treatment. And they had pre-treatment AHIs of about 28, and the post-treatment AHIs were below, like I said, below 5, and the AHI, average AHI was 1.23. And the arousals were about 14, 15. Here we can see this a little better. 14 of the 40 patients, they had post-treatment AHIs below 2. That's 35% of the whole group. Holy smokes, can you get 35% of all the patients you treat below 35? That's about 70% of the group of 20 that were with 5. But look at, here's where the AHIs were. Down at the bottom, the very bottom row. Come on. Was the average AHI was 26.59. Look at what with the O2, it was 0.7, and we got the mean oxygen to 96.8. And we got the arousals to 10.8. These are the results we want. 8 of the 40, 20%, had AHIs less than 1. Let's go right down again. On the left, pre-treatment AHIs 21. Look at what the average of the 8 were. 0.33, and you can see the readings for each one. The mean oxygen 96, and the post-treatment arousals 2011. And 18 of the 40 had over 30. Started it was 40 was where we were. We got it down to 13 for the group, and we got about 96. And the arousals were 16. Look, these aren't fabricated numbers. These are from lab studies, and this is what the compilation was. I'm the messenger here. All right, we got 2 sleep studies I want you to show you. The first one is with oxygen, and look at what we had here. The top red line, AHI 0. Now, John Nadeau showed us a case with 0. That was great. Well, we've got 0 here. And we've got the mean oxygen is 97. And the arousals were 5. Now, this is an interesting one. This was one treated by the University of San Diego at La Jolla. This is at their sleep center. The patient came in for me. They wanted a full breath. We got them a full breath. I wanted them with the tubes. I wanted them to run the oxygen. They would not. So they ran just a regular PSG with the mouthpiece. Look at the AHI. I never had an AHI 0 without oxygen. I was very happy. Okay. Here's the concentrator, if you haven't seen one. This one on the left. Here's where the concentrator with the cannula hooks to the mouthpiece there. And it goes all the way together, long 6-foot tubing that fits on right here on the concentrator. I turn it on here to 1.5. Quiet. Brings the oxygen, and we've used the tail to open the airway. That's how we're getting these results. Now, this is horsey. I roll it into the closet during the day. There it is, fit on again. Now, let's see if we can get this to work. No. Okay, so that was a video. but I usually have to do it with my mouse, and I don't have a mouse here. Okay, what else can we accomplish with the full breath? No, we're sorry. How can we as dentists treat systemic cancer, infection, and virus? We can't. We can't. But we can sure as hell treat the apnea and snoring. And when with all these people snoring, and they having 95% having apnea, we just as a fallout are treating all these comorbidities. And if we hook up with an MD, we can get him wanting to use our mouthpiece. The CDC states there are 117 million Americans with chronic disease. Warburg says O2 can reduce or eliminate infectious bacteria and virus. Can the full breath provide the O2 needed to affect these 117 million? I think so. 8 of the 10 leading causes of death as listed by the CDC are exacerbated by hypoxemia and acidosis. And here they are. And you got the bipolar and depression. Dentistry can be one of the professions at the top treating and providing health maintenance. Key thoughts when treating OSA. Otto Warburg leads the way. Hypoxemia, hypoxia, and acidosis are the plight of mankind. They saturate the body. Dentistry can provide successful treatment when treating OSA. How do these affect the bone? How do they affect the supporting bone of the maxilla and mandible? Well, what could cause this to fail? Now, I haven't done general dentistry for 20 years, so all the reasons that the reconstruction can fail are way beyond me right now, but they're there. But how about the bone itself? Could the bone fail? Yeah, it could. It could. How will the implants maintain if the patient has O2 saturations, and you can see these? How will the periodontal patient hold up? Osteoblasts and osteoclasts are involved, and this was really surprising to me. The American Association of Orthopedic Surgeons, 10 million people have osteoporosis. 18 million are at the risk of developing the disease, and another 34 million are at risk of osteopenia or low bone mass, which can lead to fractures and other complications. 62 million people at risk under the osteoporosis umbrella? Well, wait till you, okay, read that. Now, look, this is unbelievable. This was in a scientific journal. Recent work shows that hypoxemia blocks the growth and differentiation of osteoblasts, those that form bone, those cells, and thus bone formation, while strongly stimulating osteoclast formation and bone resorption. Surprisingly, the resorptive function of osteoclasts is unimpaired in hypoxemia. Holy smokes. Think that could affect the head of the condyle in TMJ? You bet. Think that could affect the bone holding in those implants? Could. Acidosis is required for osteoclast activation. That is bone resorption. Acidosis blocks matrix mineralization by osteoblasts. Hypoxia stimulates osteoclast formation. Hypoxia blocks osteoblast growth and differentiation, thus bone formation. Hypoxia causes acidosis. These responses give key insights into bone pathology. Well, holy smokes, everything we're doing treating OSA affects osteoporosis, the bone, the osteoblast, the osteoclast. TMJ, what's it all about? All right, read this quickly. All right, what was my background? Well, first of all, I got into this after about 10 years in general dentistry. I took a class with Niles Goucher and Jack, then another one with Jack Hayden, and it convinced me, man, I wanted to do some TMJ. I went to the AACP meetings, and boy, did I learn from some right people. Brendan Stack, Jack Hayden, Gerald Murphy, Bob Talley, Larry Tilley, who's here. I mean, these guys were brilliant guys in TMJ, and it really gave me a good background. I became one of the board of directors for the AACP. I became president of the Alliance of TMJ organizations, which back in the 80s, TMJ was an absolute Wild West shootout. Everyone had different ideas. It was nasty. Larry Tilley, hold your hand up, Larry, for them to see you. Larry formed the Alliance of TMD organizations, and we had them all in there. And believe me, there was a lot of nasty fighting and nasty not agreeing on what was going on. This led me into sleep. Well, what happened is Ed Spiegel, who has passed on, was a good friend of mine and told me, you got to get a pharyngometer. He says, you get a pharyngometer, it's going to show you how to open the airway, you're going to be able to treat some sleep, and you're going to reduce pain. Well, I really like that, reduce pain. I got a pharyngometer. It was tough at first, but boy, once I really got used to what's going on, wow. I saw that as I was working, and I made changes on the mouthpiece, we got big results with the opening of the airway. So that led me going into sleep. And now we're hoping to get within the ASBA a TMJ subgroup. None of the sleep groups have a TMJ group. We'd like to have one, and we really should, there should be one. For all you guys doing advanced, which you all are, we want to give you a lot, we'll get you a lot more well-armed to protect yourself. All right, here's some basic stuff. All right, here's a condyle. We're in the glenoid fossa. We can see it's pushed back against, this is the ear hole. We want it to slide forward, and here we go. We want it to slide past this tip of this bone. Here's this side, same thing. We want it to slide forward past the tip of this bone. It has. Good, that's nice, we like that. All right, now here's another one. Good bone, the bone isn't come on. The bone isn't worn down on the top, but look at how there's good spacing between the tip of the bone and the eminence. That's room for the disc. So this would at least give me a hint that the disc is still in place, and this is probably musculature. Problem. All right, I put this in because I want you to know that this is a great picture, but it's undiagnostic for the condyles. And if you're going to get pictures of the condyles, you need tomos, at least, tomograms. All right. Here's the condyle again. This is our same picture. Here's the condyle. Here's the disc on top of it. And as we slide forward, we see the disc goes with it, protecting the condyle from the bone so it's not getting worn away. And look at how there's this spacing. And that's why I made this generalization right here, because of this. All right. Well, over here on the left, there's the condyle and the disc on the top. The condyles move forward, the disc is moving with it, and the condyles move past the bone. Everything's normal. Here in the middle picture, the disc is slipped forward some, doesn't cover it the way it covers it here, and now we've popped in the middle. That's where the click occurs. So if you eat a meal with someone and they're clicking, this is all that's happening. They're clicking into the disc, and here at the end, these two look the same. You can't tell whether this is this one or this one. And here's one more. Now the disc is really slipped forward. This is a lock. And with this, as you try to open, you bang into it, and you can't open all the way. Closed lock, dislocation, and here they are stuck. All right, well, that gives you a little more of the biomechanics of what's going on in TMJ. TMJ and TMJ due to numerous sources. Take a look here. You see the sources there are. Now, here we are at the good condyle, good bone formation. But look at these three at the bottom. We've got look at this. This has an osteophyte on the front. Extra bone laid down. Here we've got the bone flattened. Here we've got degenerative joint disease. And here we've got what they call a bifid condyle. There's just a groove going down the middle. But what if I told you that all three of these, no pain, but pain here? Now, I've talked with the numerous guys, Larry Tilley, Gerald Murphy, myself. We have seen cases like these three on the bottom. Not a lot, few and far between, but there's no pain. Elliot, you and Rich may have seen some cases like this, but why would there be no pain? And why would there, with those nice looking condyles, would there be so much pain that these patients come in walking pharmacies? Well, we're going to take a look at what we think is causing this. All right, I want to give you one more bit of these pictures on the left. Here we go. Nice posture. We're starting to step forward a little bit. Now we're going a little farther forward. The muscles are getting a little more aggravated, and now we're really forward. And these muscles are very aggravated, trying to get everything in the right way. Well, they go into spasm. They cause pain. Now, look at this nice straight neck. This is the way the neck should be. Nice curvature of the neck. But the neck, through auto accidents, trauma, it straightens out. It's called military neck. And one of the guys we learned who really talked about this was Brendan Stack. And this causes muscles to be sore. And here we have high shoulder. This right shoulder is higher. The head wants to lean to the left. But the semicircular canals have got to be parallel to the horizon. Otherwise, we're going to be dizzy. So what happens? These muscles right here on the right side of the neck, they're always working, contracting. They're pulling it back. And they refer pain upstairs. Picture on the right. Look at how the right bone is longer than the left. Look at how the right hip is longer. It's goofed up all the way. And this affects everything. And here's the big picture. Dr. Janet Travell, who's the real queen of all this. Look at this muscle right here in the neck. It's called the sternocleidomastoid, SCM. She calls it the fifth muscle of mastication. Look at the X is where the spasm occurs, and the red is where the pain. Wow. Wow, wow. Let me tell you what we think is the key on here. Every day, every one of us in this room, everyone on this planet, we are inundated with insults from our environment on our immune system. Agreed? Yes. Diet, alcohol, tobacco, whatever else is what we breathe in. There we go. And it's hundreds and hundreds. And you build this up, you build this up, you build this up, and finally it builds up in the immune system right here. You hit enough stuff right here. It's trying to stop it. But you break through the immune system. Now what? Immune system is broken down. We get body breakdown, we get illness, we get pain. Any arguments on that? No. That's it. And with that, we got all sorts of stuff that causes it. Now the question is, what percentage of all this stuff that's built up is hypoxemia and acidosis? And can we, with all this new paradigm, do something about it? Now, I was in the AACP, just a beginner. And up walks this guy from Calhoun, Georgia. Is that where you're from, Larry? Calhoun. Oh yeah, Larry also claims to be a fifth-generation descendant of Jefferson Davis. Only kidding. Larry gave a talk, and he called it the bucket theory. And he talked about everything being dumped into the bucket, and then the bucket overflows, and hell breaks loose. Now the problem was 30 years ago. I heard it and it impressed me, but I didn't have the ability, nor really the desire at that time to do much about it. But I got to tell you, Larry, you were miles ahead of everybody else, and I thank you for that.
You have to know Bryan. You can't talk with him 12 minutes without hearing about USC. And so I got to thinking, I bet you there's been a rivalry over the years with Georgia. I'm a Georgia fan, of course. And I started looking it up, and I couldn't, the last game I could find was in 1960. We do play UCLA this year. But I found something about it in this magazine from 1960. We played them in 1931. We were beaten 60-0. 33, they beat us 31-0. And in 60, we only got beat by 7. And Fran Tarkington was our quarterback, and he broke every record in the country that year. So that's what we got to look forward to. And all I've got to say about them is kiss that.
There you go.
And I didn't even know he kept talking about USC. I thought he was talking about the University of South Carolina all that time. So here's the crux of what I want to tell you. If you're going to treat these sleep patients, you have to know about craniofacial pain and TMD. If you're going to treat craniofacial pain and TMD, you've got to know about sleep. Now, I've got to tell you that Bryan and I Bryan and Ed and myself were the three people in 1995 who were put in charge of our sleep group there in AACP. And we were supposed to come up with a course, and we were supposed to come up with other training and other people to speak. And we had a tough time getting it off the ground because everybody was worried about pain, and nobody thought this was all that important. And I'm one of those people. I didn't think it was all that important, and when somebody didn't get better or I got through with the patient, then I'd look at sleep. That's not the way it works. Let me show you a couple patients. This young lady was a patient of mine when she was young. She had a reciprocal click back then, but she had no pain, no discomfort, wasn't going to have orthodontics, although she could have used a little, and so we didn't do anything about it. So she got married, moved away, and her new dentist, her husband's dentist, made her a sleep appliance because she wouldn't wear her CPAP. And this is what happened. She only touched her front 2 teeth. So this dentist had changed her bite so much, and she was so upset that she had a lawyer going to sue this guy. And another patient that same year came in with the same problem. Now, this is the lady's CT when I did it 7, 8 years ago. And this is it with her like this. Doesn't that look like a perfect position for the joints? This guy just treated her joints. He captured her disc, but he didn't know that. But you know, there's an old saying about if you tell them after the fact, it's an excuse. And even though I was trying to tell her that and diffuse the situation, she wasn't biting. He did this to her. Then I had this other lady come in a few years back, Christine Campbell, and this is her intake form that I still use. Matter of fact, Bryan was talking about us being ahead of our time. Bill Williams was in our study club. He was one of the founders of the Atlanta Craniomandibular Society. Bob Finkel was in our group. And we were just so lucky because Joe Konzelman, one of our members, was a good close friend of Travail's. Dr. Simon's wife worked there at Emory, and he worked there, and so we got to be with them a good bit. Roccabato, when he came to the United States, came to Atlanta to work for a guy named Stanley Paris. So he came to our study club. We heard him quite often. Farron McCarty, we're down the road. It was just a fortunate time. We were just in the right place at the right time. But we were light years ahead. I'm thankful for that. And Christine was one of those patients that came in, and I'm looking at this same form that I used back then and looking at everything she had written down, headaches, facial pain, neck and shoulder pain, and I felt pretty confident that I could handle this case. I looked at her pain pattern that she drew and thought, that looks pretty familiar. And so like so many patients, when they ask where they hurt, it's not the joint, it's here. What's there? So these are her x-rays, her CTs, and there's no doubt that her condyle is distally displaced. Well, there's this thing called an arthrokinetic reflex that's in all the joints, and if a joint's being damaged, this arthrokinetic reflex kicks in and causes muscles to go into contraction. So they stay contracted all the time trying to protect that joint. So I figured that's what's going on. And then the other thing I thought might be going on is a myofascial problem, because that's the number one thing we want to look at. That's the arthrokinetic reflex I just mentioned. And what's so important about it is that muscles, their function is just like the police, is to serve and to protect. And so if these muscles, or this joint rather, is being damaged, then the muscles go into a reflex spasm to protect it. So if they're holding that to keep from damaging that retrodiscal tissue, then what's going to happen is the muscles are going to get tired. And a great example of that is if I just set my chair with a thumbtack in there and I avoid it all day, my muscles are going to get really tired. And that's easy to make the patient understand. Then the next thing that I thought of is this. This is Weldon Bell made this statement. He says that a good rule to follow in diagnosing pain about the face and mouth is initially to assume that the pain is dental until proven otherwise. However, pains of muscle origin are the most frequent cause of discomfort about the head and the neck. So how many patients have you seen that are sent in for TMJ problems and they have a pericornitis, or they have a fractured tooth, a cracked tooth? And that's the first thing you have to think of. But then the joint usually doesn't hurt that much. There can be some serious arthritic problems, and certainly they can, but most of the pain comes from the muscles. So you've got to have this book. This is the most important book you'll ever have if you ever treat any pain patients, and if you ever have any aches and pains too, because you can find the aches and pains that you would never have thought possible in that book. And I looked at that lady, and her main concern, the number one place that hurt, was around the ear and the joint. So I went to this page and I looked to see what muscles refer to that area. And the muscles that refer there are all of these muscles right here. So we've got the lateral pterygoid, the masseter, sternocleidomastoid, and medial pterygoid. So let's look real quickly at these. The lateral pterygoid's here, and I have the patients look through these and take a look at these referred pain patterns to see if any of theirs are like this, and hers were. The masseter is a biggie. We see a lot of pain into the ear. People are about my fourth most common referral is pain deep in the ear with no infection. And SCM causes all kinds of problems. One of the things we see is something in the throat. like they've got something caught, sinus type pain, pain behind the eye, pain in the back of the head, forehead, ear, and one of my favorites is the hair hurts. And every physician says, you're nuts. I have patients coming in all the time that say their hair hurts. And it's really evident from this. It also causes light sensitivity, dizziness, ringing in the ear, and a whole bunch of other sympathetic symptoms. And that's the medial pterygoid. So when you take a look at that, that's the kind of pattern that you get from all of those muscles. And if you take a look at this lady's pain pattern, doesn't that look just like that? So I'm going, okay, this is mostly a masticatory problem, and I do know that she's got some, and then the temporal tendonitis that we talked about, and you have them open, you just push in, come down beside the eye under the zygoma, have them put your finger in there and have them open wide, and if it rubs across there and it's tender, it's temporal tendonitis. It's not the temporal muscle itself, but it's it's inflammation of the tendon as it attaches to the cornoid. And those are the symptoms that you see: pain in the ear, in joint, tooth sensitivity, cheek pain, eye pain, temporal headaches, neck and shoulder pain. And I had a lady with pain in her teeth that went to her dentist. She had big fillings. They crowned all of her posterior teeth, all 4 of them on that side. That didn't help her pain. They sent her to the endodontist and did 4 root canals. That didn't help the pain. And they took all 4 of them out, and her teeth still hurt, even though they weren't there. And so we were fortunate enough to think about looking at the masseter muscle, and sure enough, that helped her pain. And then this was Christie's TMJ report. I don't know if anybody used the TMJ scale. It's the most incredible thing you've ever seen because it's got a whole lot of information, but this is the summary. So I looked at this one. This is the global column, and it tells us the chances of her having a TMJ problem, 98%. These all reflect on it. This is her pain report, very significant. All these lines going across are points of concern, so anything above that's a concern. This is her palpation pain, meaning she found places that hurt. This is her malocclusion. She knew she had something going on bite-wise. This is her joint noises, and this is range of motion. This is non-TMJ health issues, and headaches could be there, a whole bunch of different things. And this is psychological factors. I'll come back to that in just a minute, right at the end, and explain that one to you. But this is great information to have before you start treating, and then you can evaluate it after you start treating. So I had her in all kinds of positions. I had her in a neuromuscular position. I had her in a bruxing appliance. I changed to 3 different designs on the bruxing appliance. Had her in a pull forward appliance. I had her in all kinds of things. Nothing helped. And then I had her fill out this form, this headache form again, and a lot of the stuff came from her cervical spine. So I sent her back to her chiropractor. We talked a lot on the phone about things to do, and he couldn't help her either. So she finally shows back up. And I'm thinking about the cervical stuff. And we did a study there at Emory where we just put an appliance in and held, this is what you were talking about, Brian. We did a lateral head plate and overlaid it, and look at the difference in changing the vertical just a little bit. Changes the cervical spine and the hyoid way more than it does the teeth. And so after she came in, now I looked at the airway, but it didn't register on me. So I went back and looked at her airway again. She had a Melampody of 4. She had a retracted, elevated tongue. She had scalloping on her tongue. I mean, I should have figured that out right there. And I said, talked about snoring. She didn't snore much. Her husband didn't wake her up. She didn't punch her in the night, and said she didn't stop breathing. Her Epworth was 13. So we got a problem right there. The rest of my questionnaire had 9 of 13 things that says she has sleep apnea. I did a stop bang. It certainly showed she probably was apneic. And then I looked at her. I hadn't looked at this on her CT. Look at her airway. And look at it when I transposed it into this. Look how black it is. Black is little bitty. We want them all up in here. So I've got a terribly small airway. So I sent her home with a Respironics Are You Sleeping? It's a real simple airflow meter. We can't do testing. The Georgia State Board has decided in their infinite wisdom that we can't do testing on patients, home testing. And we can't refer to a sleep center. And we can't titrate the appliance by doing testing. So it's really created a problem that so far I've just chosen to ignore, but I know that I'm going to have to deal with it sometime. This is the little "Are you sleeping?" All it does is airflow, but it's 92% sensitive, 77% specific, and her apnea hypopnea index on this one was 30, and she only slept about 3 hours. The next night it was 85. The next night it was 70. So when I averaged those out, she had an AHI of 60. And I'm just beating myself to death about how stupid I was. And that's from my bringing up of in AACP of, yeah, sleep's important, but we'll check it at the end. It's something that has to be checked at the beginning now. You can't wait till you get there. Occlusion, we talked about a little bit. I'm going to skip this because I had deleted it on another one. But the big misunderstanding is about jaw position. This little girl started here when she had ortho. I want you to look at her teeth. Would you bet that her mandible's retracted? She's got 100% overbite. She's got buccal bite on the back. She's got crowding. Her mandible is terribly retruded. I don't have a picture of her condyles to show you, but you can bet they're retruded. This is her after the orthodontist got through, and they look pretty good. But the problem is, she was built in that same occlusion she was in with straight teeth. So it doesn't matter what the classification of occlusion is, because it's where the jaw is in relation to it. This is a lady that had perfect teeth, and I took no symptoms, no palpations, and I took a CT on her. This is the perfect joint. And this is the one I use to show patients. Nice cortical bone, plenty of space, and this is the middle slice that is just perfect, like Bryan was talking about, in the anterior aspect of the fossa. But look at this side. Now her teeth are perfect, remember. Look at the space here compared to here. Is it less? You bet. Look at this. It's not bad. It's in her physiologic adaptive range, but it's in the middle of the fossa. It's not in the anterior part of the fossa. So what does that tell me? It tells me that in her occlusion, her mandible has to sit over here like this. So she starts off with perfect occlusion, but with a mandible shifted to the right and elevated on that side. That's the problem. It's not about classification by any means. I'm going to skip a couple things because I redid this for a little less time. The NIDCR has some really interesting things to say. You can't buy this brochure, but you could go on there and get it, and you can find out that nothing we do works. That other thing that was up there was the American Dental Association's consensus conference. We filed suit against the ADA, the AACP did, because the results of the meeting was already being used by insurance companies to deny claims before the meeting took place. And what the report said, and it said not to be referenced, stamped across the front, and what it said was there's nothing that we do that works. We don't have the ability to diagnose it or treat it, and the only thing that works is EMG biofeedback and cognitive behavioral therapy. So we filed a suit. And I have never been to the ADA with a group, that alliance group or anything else, that there wasn't an attorney in the room after that. So it really gave us a black eye. The summary of the whole thing is there's no relationship of occlusion and TMJ. Now, Kaplan Cell has a perfect picture of a TMJ on the book, but if you read their information, I'm going to jump through this too. This is what it said, same thing Dr. Graber said. Clearly, the overly simplistic and mechanistic conclusion that dental occlusion was the basis for most TMJ abnormalities was patently wrong. Occlusion has nothing to do with craniofacial pain and TMJ. Really? What do you think? Who thinks occlusion has something to do with it? Who doesn't? Who doesn't? Good, I want to talk to you. Here's why. So I'm not the brightest thing in the world, and Dr. Cummings, Joe Cummings, Bill, you remember Dr. Joe, he made this statement that if you'll just shut up and be quiet, they'll tell you what's wrong and what to do about it. And these patients come in all the time. Had one come in with she always had a wash rag right here. Another one had a Pringles can that she had cut to wear over her teeth. These people figure it out, but we don't think it has anything to do with it. Dr. Witzig sent me this slide many years ago, and he said that the problem with TMJ is dental malocclusion. I don't think that's right. I think it's normal occlusion. I think it's the way the teeth go together and not necessarily a problem. So it can be like Keebler cookies and be elfin magic that causes TMJ, or it could be unidentified biomarkers, millions of dollars has gone into that research, or it could be a biopsychosocial issue, or it could just be occlusion. Now, Dr. Ricketts said years ago that the position of the jaw is dependent upon the muscles and the length of the ligaments when it's at rest. But when it's an occlusion, what puts it there? What happens to the condyle, rather, when your teeth are in occlusion? The condyle just has to go wherever the teeth make it go. The teeth win. So I think that the etiology of craniofacial pain is occlusion. Burt Reynolds made this popular in the 1980s because he had such information out about him having something wrong, and one of my friends treated him, and he assured me there was a lot more wrong than TMJ. But when you start looking around, you'll see chiropractors who treat the same thing we do. Any of you get a patient that the chiropractors treated the TMJ problem? Happens all the time. What can they treat? Do they help? My patients say, yeah, they feel better. Are they treating the symptom? Yeah, that's exactly what they are. They're getting him back into a physiologic adaptive range, but they can't treat the problem if it's occlusion, if we're right about that. And dentists treat the same thing. We're seeing ads from dentists who treat headache and neck ache and jaw pain, like the academy used to be called the American Academy of Head, Neck, Facial Pain and TMJ Orthopedics. And that didn't look good on a business card, so we had to change that, obviously. But our naysayers call us the Academy of Everything for that very reason. So you have to wonder why, and you have to wonder how all those people can treat things. But all my patients talk about going to the acupuncturist and the chiropractor and the physical therapist and having improvement. And you got to wonder why. And it's all about your point of view, and you only see what you know, or you only see what you can treat. So Bill, these are some old slides that you did, as a matter of fact, I believe. And that's his point, is the point of view is everything. And Bill had this one made. He said he had seen people that had gone to all of these people. Physical therapist says it's the posture, and evangelist says the lost soul, dentist says it's a bite, and all of those things help some of these patients. The truth is, signs and symptoms don't match, and pain and dysfunction don't match. You know, people can have a clicky knee rather, and not have any pain. Do knees click? Not normally. They're not supposed to. What about a clicky joint? Yeah, my joints click for years, but I don't have any pain, but they still have a dysfunction. So that's the big problem that we don't understand. This lady came in because she had a tooth that was bothering her, and she had a tooth that was worn into her nerve. And I did a root canal on it. And a couple days later, this lady came in. And so when you look at these two patients, which one would you pick that's hurting? And the truth is, that's the one that was hurting. She had just gotten out of ortho. She had her bands off, had retainers placed, and the teeth aren't mobile anymore, and she's biting better because her teeth are more stable. And what's that doing to her condyles? What's that doing to her muscles? Are the muscles having to rotate and torque like that lady I showed you a while ago? What about this lady? Has she got a dysfunction? Yeah, she's got a big dysfunction. She's not in pain. That's pretty amazing to see that. And the reason for that is just her physiologic adaptive range. Some people have big old physiologic adaptive ranges. Some people have little bitty ones. Those kind are the ones that are pushed over the cliff by just a feather. And some with a big one like her, she could probably tolerate anything. So this is what Bryan was talking about. I came up with this idea a long, long time ago when we saw pictures like people like that rather. And we decided that the body was like a bucket. And in this bucket are all the things that we have wrong with us. And Joe Konzelman used to say that people can have as many things wrong as they want to. And so this person has a TMJ problem, has a leg length discrepancy, has a Morton's foot, has a digestive enzyme deficiency and nutritional problems, but they're 20 years old. They're not having any symptoms. But then that 20-year-old's in an auto accident and it knocks off part of that bucket, so her resistance is gone. And she starts having symptoms in the weakest area. Could be hip, doesn't necessarily have to be TMJ, but on this one it's the top one. So she starts having symptoms and we've got to treat it. Now, one of the reasons that people can go to, say, a nutritionist and get better is these things are handled and then all this drops down deeper in the bucket. Or they straighten out their Morton foot, and I can't tell you how big a deal that is. I have a Morton's foot, and used to have foot problems all the time, and wearing a little 2-inch piece of felt has changed my life. Dr. Travell taught me how to do that one years ago. People really have leg length discrepancies that can be functional, but most of them are pelvic rotations, and then certainly we know about TMJ. So as time goes on, the bucket wears more, and all these symptoms may show up. So to treat that is a much more complicated case, like Christy that I showed you a while ago, a basket case. And the medical community would just raise the sides of the bucket. They decide she's a hormonal woman and in postmenopause, and she is overly anxious, and she's stressed, and she is all of those things. But instead of just raising the sides of the bucket, we want to take things out of this bucket too and make her healthier. So we want to address it from both sides. So it's not a psychosocial problem as the guys talk about. And when you send people to look up TMJ and craniofacial pain on the internet, be sure to tell them there's two philosophies. There's us clinicians that think it's a structural functional problem, and there are those that think it's a psychosocial problem. Doesn't mean they wouldn't use the splint for 2 weeks, part-time, or let them sleep in one, but we think a little differently. And I don't think it's psychosomatic. I don't think their pain is coming from their head, but I think their pain can affect their head, and that's somatopsychic. That's what we're dealing with. There's a thing called a life events questionnaire that we've always used, and it has things that have numbers beside them, and if it adds up to 100, then you have a chance of some health problems within the next 6 months. And the interesting thing, death of a spouse is number one, but look at marriage and having a baby and all kinds of different things that are positive also cause stress. So that's something we used for a long time until that TMJ scale came along. This is my Katie, who got married a few years ago. That's my youngest daughter. You talk about stress. I thought she was going to die, and I was going to die along with her, financially and emotionally. And this was her just weeks before that, it seems like. So if you don't use the TMJ scale, ask them these questions. What's going on in your life? Does this TMJ or whatever, does it affect your social life with your friends? Does it affect your family life with children and relatives? Does it affect your work life? Or does it affect your personal life with your spouse? If somebody says, no, I'm tired when I get home, but I can go out with my husband to dinner, and I get home and bathe the kids and get them to bed, and then I'm tired. I'm really exhausted. That's a whole different story instead of one that says, oh man, yeah, I can't make it hardly at home at night, and my kids are running around wild, and I just don't have the energy to deal with them, and I don't want to cook dinner. You got a much more complex case, so you don't need that TMJ scale for that. This is a guy that has come to see me back in '09, and this is his form. Now, I was always told that if you're trying to palpate people and make them understand that it doesn't have to hurt, the one place that never hurts is on the tip of their nose. Not this guy. That should have warned me right there. I've treated him every way known. He still wears an appliance, but he's had knee surgery and hip surgery and shoulder surgery, and I mean, he's just looking for the final answer. And this is his TMJ scale that I saw back then. Notice how high everything is? But I said I'd come back to this psychological stuff. This is psychological factors. That means this problem has become an emotional issue, and it's way up above the norm. This is stress. He's got a handicapped daughter. He works long hours, and I know he's stressed, and he would benefit from that. This is chronicity. It means either it's been going on for a long time, or they have the personality to develop a pain spasm pain cycle, and it's a self-perpetuating thing. If I'd have thought back then, I would have gotten him to the psychiatrist in '09 instead of just recently, well, about 6 months ago. So it's a big deal, and it's great to know that before the fact instead of after the fact, because it's like after the fact it's just an excuse that why I wasn't able to help him. And if I'd gotten him some help then, he may be better off now. So these patients come in with pain. They hope we know what we're doing. And this lady came in just like that. This is what's sitting beside the chair. That's what's in the box. That's what's in the bag. And that's her teeth. Equilibrated 14 times in terminal hinge. That didn't work. So they went in and did surgery on both joints. One of them didn't work, so they did surgery on it a second time. This lady was just a basket case. And I'm thinking, the God syndrome kicked in, and I went, you know, nobody's treated her away from terminal hinge. Everybody's put her back way far. So why don't I just put her in a relaxed muscle position, build her vertical up, make her a stable denture, piece of cake. Nothing worked. So that's her. I don't know how that other one got in there. That's her when I'm doing, I'm doing a sphenopalatine ganglia block with some medication, trying to get her some relief. Nothing helped. This lady tried to commit suicide. She told me she was going to if I couldn't help.
Did you help when you built her bite up and come? No.
Nothing helped. So she was a pitiful thing. She tried to commit suicide. They put her in a mental hospital, stayed there for a while. They put her in a rehab center. Then they put her in a nursing home. She quit eating, quit living, and eventually died. And we, Dentistry, killed that lady. We offered her that hope for the pain she was in, and yet we didn't know enough to deal with it. That information about putting her in some position other than terminal hinge was out there when that happened, but these dentists didn't know it, and this was a real well-known guy in Atlanta that treated TMJ, and he had her teeth ground off so everything hit just perfect. So the point is, this is a really complex thing. TMJ is not that hard. Don't let it scare you. It's just complex sometimes. But if you're doing sleep, you better learn it. And if we're TMJ guys are doing TMJ, we better learn sleep. The frightening thing, there's guys out there, the advertising is just unbelievable. There are guys that go to a weekend course and then start advertising that they're superstars at it. And you know how long you've been studying. I've been studying it for years. I still don't have it all by any means. So what you have to do is you have to always go back to diagnosis. Ben Moffitt said this many years ago. And if you don't know it, call in somebody. The beauty we have with that study club is we'd have patients like this all the time, and we'd bring them down to the study club, and 4 or 5 of us would look at them and go, well, here's what I do. Let's try this. And we need a tertiary care center, but there's not one. And there's no university pain clinic that can handle these things either. So it's really important that you learn it for your patients. So I hope you'll take this information, and I'm sorry I had to rush through it so fast, and Bryan had so much more stuff he needs to share with you that's really exciting about that full breath. That's one of the most exciting things I've seen in a long time. And it's not near as bulky as having a double arch appliance. The one we used first was one, we got hooked up with Hallstrom in about '95. That's what led us to doing what we were doing. But the first one we learned about was in '84. It was called an Equalizer. And it was a monoblock appliance. I had a sleep physician send me his wife. She was worse in the appliance than without it. So that's something you got to be careful about too. You've got to titrate those patients. So thank you for putting up with me. Go to the bar.